Hello there, good evening. I'm glad to have you join us on Health Matters today. And remember, Health Matters is a program that we talk about your health and my health and our health. And you know that health, they say, is wealth. And so we are here to discuss. We talk about different issues. We try to enlighten you. We educate. We also inform you on what you should do to stay alive. And today, I'm not alone in the studio. I have Dr. Anike Major, who is the Executive Director of Care Life Foundation. Hello, Doctor.
Welcome. Hello. Thank you for having me on the show.
Okay, and I remain your host, Umo Basi Edit. What are we discussing today? Today, we'll be looking at the maternal and infant mortality rate. You'll agree with me that a lot is happening to our young mothers, and people usually say that no woman deserves to die while bringing life to the world, but a whole lot is happening. We don't know what is going wrong. Is it the lifestyle? What are the issues? So Dr. George will be here. Is here already to tell us more about this maternal and infant mortality rates and what is expected of us. What do we do to bring down the increasing rates of mortality? Okay, doctor. So talking about maternal and infant mortality, tell us a little more about it.
Okay. Thank you for having me once again. Maternal and infant mortality in Nigeria has been a very burning issues in the health sector. It's rightly said, no mother should suffer fatality while trying to produce another life. Statistics has revealed that currently in Akwa Ibom, where we are, we have 774 deaths in every 1,000 live births. That is for mothers. And for infant, we have 70 deaths per 1,000 live births for every infant. These things are not nature-made. These things are man-made. I'm not ruling out that nature plays a role, but there are a whole lot of drivers that is making us be where we are. There are so many things that should be done and things that are not done that's making us have this data. For instance, if I zero in to the perspective of nutrition, which is part of the drivers of infant mortality in Akwa Ibom State, making reference to the recently released NDHS data 2023 over 2024, you'll be surprised that stunting, as at 2018, where we had this last data, was at 19.6%. But as we speak, stunting in Akwa Ibom State for an Akwa Ibom child has risen to 24.1%. It may sound, the numbers may sound very little, but this is in percentage, this is high. Wasting was just at 4.2% as of 2018, but as I speak, it has risen to 11.8%. Imagine the gap from 4 to 11. Children in Akwa Ibom are wasting. And if you talk about underweight, it's left from 8.9% in 2018, and currently we are talking 22.6%. That is just one driver. You look at the aspect of maternal mortality, where a pregnant mother is trying to be delivered of a baby. And so many drivers now intersect between the mother delivering the child and the actual delivery itself by a skilled birth attendant.
Okay.
Religious factors, cultural factors, even this nutrition. The last project we did, imagine in a particular LGA, instead time to be precise, 172 mothers were checked for anemia. We checked anemia in pregnancy. 75 of 100 were anemic. That is on its own a driver towards maternal mortality. So there are so many drivers that lead to this. We talk about access to healthcare services. You know, in 2014, In 2024, before 2025, we did a pilot in Ibesipo or Sultan local government. When I saw this data, we pulled our team together. Let's go see what's happening in the field. Let's ask questions.
Yeah.
Mothers, what are the problems? Why don't you come over to the hospitals, to the primary health centers to deliver of your babies? And all they will tell us, we had some cohort of mothers say, the distance is so far from where we are. I was even surprised when I learned of a mother talking about the treatments from a healthcare worker, you know. And these are barriers as well. The cost of accessing care, they believe that traditional birth attendants would treat them better than a trained and skilled healthcare worker. You know, to our traditional birth attendants, you go there, they pet you, they make you feel good, they cook food for you, and these mothers would rather go that way than go to a skilled birth attendant who can manage anything that comes out of it. Religious influences and so many other factors. So we just needed to test the waters. What we did was simple. Let's see if we break these barriers, if we are going to have 100% of mothers deliver in the healthcare facilities. It is a known fact in Akwa Ibom that if we have 100 mothers who come in to register for antenatal, and you follow them through to the 9th month of delivery, you will only see 7 out of 100 actually go back to deliver in the healthcare facilities. And this data, when we are talking about this, we are not telling you to stay in town, you know, in the urban area where you have general hospitals and where you have people with good economic status. Go to the grassroots. This is where we are taking the statistics from. So if you have like 7 out of 100 who registered for the antenatal at the inception of the pregnancy go back to deliver, then there is a gap. Something is in between. So what we did was very simple. We went to each of these healthcare facilities. We sampled 65 pregnant mothers. We went to the healthcare facilities. In Ibesikbo, we did 2 primary health facilities. We liaised with the Primary Healthcare Development Agency. The director of PHC there selected these 2 facilities for us. We paid their delivery fees. We provided mama kits for them. We spoke with these mothers. We give them maternal literacy. Give them reason why it should be A and not B. We went as far as giving them infant kits for the expectant babies. And we deployed our team in Care Life to follow them up. It was amazing to say that all the 65 mothers delivered in these PHCs. Because what excuse do you have any further? Your delivery bills have been paid. You've been told what and what not to do. We've given you all the kits that you need. So by the time we saw that, it made us believe that these barriers are things that can be mitigated.
Of course.
We just need to do the right thing.
Okay, Doctor, as you mentioned religious factors, you talked about the traditional birth attendants and so many others. So I would love us to take these issues, these factors one after the other. But looking at religious factors, I know that some women have had to lose friends because their doctrine doesn't allow for CS, and then they go into emergency and they need to bring out the child through CS, and they will say no because they don't need to do blood transfusion and all of that. So in cases like this, what do you think could be done to save lives?
You know, religion is one factor that so influences everybody. This is even beyond the pregnant mothers. And looking at our context here, Akwa Ibom State, you know, churches are everywhere.
Of course.
Statistics also have shown that, I don't want to mention some specific churches.
Please don't.
Where you have these churches is directly proportional to where you have high maternal mortality. Because prophecy will come and tell you, if you I was discussing with a friend the other day, a high profile practitioner in the States, a political appointee in the States, who is a medical doctor, who said he actually lost her cousin because just an abridged kind of delivery, and before you know it, the woman died, the baby died, because they did not move as at when they were supposed to move. And the very little thing that is just in between this life and death is a phone call. Because when this thing happens, maybe in your home, the person you're supposed to talk to actually tell you, hey, you need to be in the hospital. Probably that prophecy had, like in that particular case, they said the prophecy said, if they put a knife on your tummy, you are dead. Umanikwa. If you tell anybody when it comes, you are dead. So this woman did not call anybody. And the brother is a medical doctor. So it's as bad as that. I've learned of another case that was near such experience, only for the woman out of exhaustion now called a friend who took her to the healthcare facility. She was operated upon and delivered of that baby. So when the church people now came, they asked the woman, how did it go? The woman said, I delivered naturally. They said, I told you, if you had gone through surgery, you would have died. But in actual, the woman went through surgery. Truth be told, there is no crime in blood transfusion. In fact, nature, God, that brought about this knowledge in practice was to liberate people, because it's not everybody that will have natural experience of birth. So our churches, instead of stopping the mothers, God is spirit. Jesus Christ that we pray through is spirit. Jesus can be there with you by your bedside. Allow these mothers to be attended to by skilled birth attendants. So it's a huge challenge that we are still facing. That is where maternal literacy comes into play. What are we telling these mothers in their congregations? Woman, code fasting, what are we telling them in these kind of setups? We need to make our mothers to understand that a greater percentage of maternal mortality in the States. Why I'm saying in the States, although if you advance a little bit into the north, it's not really this aspect of religion. That may be more of cultural, where the husband is telling the wife you cannot go to the hospital. But here in Akwa Ibom, our men, to some extent, I know, will not stop their wives from going to the hospital. But the religious influence is actually stopping them. These we need to mitigate as well.
Okay, and then that takes us to the next one. Talking about, you said they actually believe that the traditional birth attendants will treat them better, but that is reality. I must confess, yes, it's reality, because if you go to the hospitals, you understand the nurses are not very patient. I'm a woman, so we know those things and we see those things. So let the truth be told. In this case, sometimes they actually almost beat up the women. Not be me send you when you've been laid. You understand, they're nasty and they're rude to some of these pregnant women. And you know that some people manage pregnancies differently. The way one person may get pregnant and be going to the farm till the day she puts to birth, but it's not the same as the second person.
That's true.
So I think the healthcare workers too have a lot of roles to play in this.
Healthcare workers' attitude contributes to the barriers, the drivers of high maternal mortality. First off, the traditional birth attendants are the people you know. They live within your locality. So you will hear someone say, minor, ma this. And they know that since we are staying within the same locality, after this experience we will still meet together. But the hospitals are not, the nurses in the hospitals, the healthcare providers are not people you know. But professionally, you are trained to be able to handle any person, that be it a pregnant mother or not. But in this context, to the pregnant mothers, you are trained to handle them with care. You are trained to make them feel relieved. Where the experiences I've gotten in the global stage, a hospital is a place that by the time you just enter the place, even before they start administering any form of medication, you are half well.
Exactly.
So it is really true that our healthcare providers are
not
not
nice.
doing what they are supposed to do.
Not nice.
I would not say they are not nice.
Some of them.
Some of them
are not nice.
you know, because a woman that is laboring, it's okay for you. What do you want to tell that woman, you know, to really understand, for you to understand the pains that person is going through, you know? So if our healthcare providers, part of what we achieved during the IBOM Open Maternity Project, having to retrain our healthcare providers, talk to them. We even spoke as well with the traditional birth attendants, telling them the do's and the don'ts. You cannot compare a mechanic to an engineer. An engineer understands beyond what a mechanic will do. So it's safer for the mothers to go to the hospital. And if it so happened, this was an emergency, that the traditional birth attendants and Nyewomi has, you know, been called upon to be of help. For me, I would say that should be a first aid, while calling for help to take this mother to the hospital where proper care will be taken. So these are some of the drivers, right? Yeah. That is really causing a high rate of maternal mortality in our communities.
Thank you so much, Doctor. If you're just joining us, the program is Health Matters, and today we are looking at maternal and infant mortality. I have with me here in the studio Dr. Nick George, who is the Executive Director of Care Life Foundation. And so, Doctor, you mentioned nutrition as one of the factors. Let's go there.
Okay, I thank you so much. Anemia is directly proportional to poor nutrition, because what you eat reflects your body count. Let me put it that way. Now, both mothers and infants and children, let me not use infants now. I had talked about the data from the NDHS that was released 2018 as compared to 2023, 2024. We may feel nothing is happening, but we should actually declare a state of emergency for nutrition intervention in Akwa Ibom State. We just finished the IBOM Open Maternity Project, where we leveraged the 2025 World Breastfeeding Week through 7 local government areas. And I can tell you that we recorded a whopping 284 severely acute malnourished children. These are children that if you carry them in the hand, they are as light as weight. And there are so many factors that also contribute to these. Economic factors cannot be ruled out, but the first thing is, what do you know? Because we have supporting systems around, little things that you can put together to help your child and to help yourself. Let me use that. Our normal vegetable here in our backyard. Some little things that you can put together for home feeding can actually mitigate these issues. There are other drivers to it as well. Sicknesses can be a part of it. I cannot rule that out, because you don't expect a child that probably has HIV to be as healthy as a child who is not immunocompromised, right? But ruling all these things off the table, why are we still having a high rate of malnutrition at the grassroots? That is the big problem that no one is talking about. I wouldn't have known it myself. When I saw the data, that is what propelled me to put our team together, call other partners as a coalition to come together. We used the IBOM Open Maternity Project as a machinery to reach out. And what we saw in the grassroots, I think if they want to revisit that data collection again, it will be more than what we've got here. So, our children are dying because they are malnourished. We did not do much. There are people that were severely malnourished. There are some that were moderately malnourished. And we have a good number as well that are not malnourished. But for those ones that are severely malnourished and moderately malnourished, We call it the red zone and the yellow zone.
Okay.
Every child should be in the green zone. So all we did, we deployed, thankfully the state nutrition officer led the team with the local nutrition officers, because mitigating that gap is not a one-off thing.
Sure.
So we introduced our treatment measures, but we still need a follow-up. So as I speak, we were able to help each of those children have the treatment course for over a 4 weeks period.
Okay.
Now, after 4 weeks, we need to go back and check where is this child actually. But that 4 weeks course meal that we gave to these children should be able to take them from the red or the yellow zone to the green zone. But let us tell the truth here. There is a problem in the grassroots.
Yeah.
And like I told some of the stakeholders that were present, part of what we need to mitigate this gap is for us to establish a malnutrition assessment centers in each of the primary health centers.
Okay.
If not by ward, then at least one in each LGA, so that these mothers can actually, especially in our model health centers, that His Excellency, the Governor of Akwa Ibom State, Pastor Moino, PhD, has established. We need to leverage these model PHCs and ensure that these important aspects are factored in, because we are trying to address a problem in our communities.
Yeah.
There are partners that are ready to provide these treatments, to train the staffs. All we need is a space.
Well, I was getting to there, and unfortunately time is not our friend here, because we have to wrap up. You've been on ground, you've been in the field. Would you say that our primary health centers are well equipped to tackle these challenges? If not, what do you think government should do?
Our primary health centers, let me start with the model primary health centers and probably the operational basis.
Okay.
They are equipped.
Okay.
But there is still room to do more. When we talk about the primary health centers being well equipped to be able to respond to these kind of emergencies, we are talking both infrastructure and manpower.
Yeah.
We are having gaps in terms of manpower at the grassroots. I remember when I was doing my NYC in Kaduna, part of what Kaduna State government then did was, any staff that is posted to the rural community is paid more than staffs that are in the urban community, so as to encourage people to stay there.
True.
They also ensured that staff quarters are well furnished. These are some of the things that will encourage health workers to go there. We have NYSC core members who are doctors, nurses, and other healthcare providers who should be posted to those places to have their service years there. By the time these NYC core members are taken to these places, they find a good life in these rural communities, and they are paid probably more than their counterparts that are serving in the urban areas. They will be excited to go there. So that is one way we can solve the challenge of manpower. Same with experienced skilled birth attendants. I was talking to my honorable commissioner friend, Dr. John. I told him, sir, don't you think if we can grab young students that are just finishing their SS3, give them scholarship, we can decentralize it, each of the LGAs, into School of Nursing. 2-3 years they are done. They sign a bond to serve the government for 5 years before they move. You take them back to their communities. Give that a try over 4 years. We will naturally deface traditional birth attendants because we would have gotten enough skilled manpower at the grassroots. You see, these are little things. If we say we are starting a campaign to sponsor 10 persons per local government areas, give it 4 years.
A lot will be achieved.
Talking about infrastructure, equipment, and otherwise, our healthcare facilities are equipped, like I said, but there is still more to be done.
For instance, these malnutrition assessment units, centers, little things like weighing scales, height, infrastructures to be able to check height, and all of those things are little things that we just need to add to what we've got now to be able to roll out these issues. If we are able to establish a child is malnourished, we have a center that can review and follow up this child. I promise you, there are partners, including Care Life, that is ready to ensure all the consumables are in place.
Thank you so very much, Dr. Onyekevin George, for that very expository ideas you've given to us. I'm sure governments will be ready to partner, you understand, and key in so that we can save lives. Like I said earlier, no mother deserves to die bringing another life into this world. And so we've been speaking with Dr. Onyekevin George, who is the Executive Director, Care Life Foundation, and the program was Health Matters. Thank you for staying tuned. Next week, it's same time, same next week. Bye-bye.